Hi there, my name is Joseph Irizarry, and this is my patient Luis Alvarez. I'm going to be going over a general medical examination video to go over basic steps and tests that physicians do to determine baseline indications of health in patients. So we're going to do a variety of tests, start everything from temperature, pulse, respirations, blood pressure, and then do an ear exam, a hearing test, and then I'm going to look at lymph nodes and do a throat exam. And I'm going to take you step by step as to how those are performed. So the first thing we're going to do is we're going to go through temperature. Now, we're going to do an oral temperature today. There are other ways you can take a temperature. You could do an axillary, which is under the armpit, or for extreme cases or a very accurate measurement, the gold standard, you can do a rectal thermometer as well. But today, for a general exam, I'm going to do an oral temperature. Now, the thing to note is that a normal body temperature is 98.6 degrees. If you do an axillary temperature, it's normally 1 degree cooler in comparison to oral. And a rectal temperature will be about 1 degree higher in comparison to an oral temperature. So what you'll do is you'll just turn your thermometer on, and then you're going to have the patient open their mouth, and you will insert the thermometer under their tongue, and once it's firmly in place, you'll have them close their mouth, and you'll wait until the thermometer beeps, and you'll get the reading that you need. For the sake of the video, I'm just going to instruct you how it's done, and then I'll go from there. So Luis, I'm just going to have you open your mouth nice and wide for me. Stick your tongue up. Thank you. I'm just going to place that underneath, and I'm going to have it relax and close it. And it'll take a couple of minutes in a practical situation. It'll beep, and then you'll pull the thermometer out, and you'll get a reading. So go ahead and open up. And in this case, I got a temperature reading of 94.3. Like I said, normal body temperature is 98.6. And for this reading, it could be a little bit lower. It could be the fact that I just left it for a few moments. But that's the technique in which you use to get a temperature. So now, we are going to move on to respirations and pulse. And there are a variety of ways that you can do it. So what we're going to be looking for is the radial pulse. So Luis, I'm going to have you put your arm out like this. And what you're looking for is a radial pulse. And I'll take this watch off. And so what you're going to do is you're going to find on the radial side of the arm, right around here, you'll feel a little groove. And you're going to take 2 fingers and you're going to feel firmly for a pulse. You don't want to apply too much pressure, but you don't want to apply too light because you won't feel it either. The keynote here is that you never use your thumb when taking any temperature. Why? Because you'll feel your own pulse in your thumb and it'll throw off the reading. So here, a normal pulse is anywhere between 60 and 100 beats per minute. Anything above 100 beats per minute is termed tachycardia, and anything that's below 60 beats per minute is termed bradycardia. However, in very well-trained athletes, it is not uncommon for them to have beats per minute lower than 60, and that could be just fine. But if it's somebody who has higher, that's something you want to make sure you monitor. You may want to refer to a physician to see if there's any other complications that may arise from there. But like I said, for a general bit, we're just going to palpate right here. And what we'll do is I'm going to time for 30 seconds, and I'm going to just count respiration, or the amounts of beats that I feel, and then I'm going to multiply that by 2 to get the total number, okay? And I'm going to make sure that I have my watch set so I can easily time it and not have to worry about anything else. All right. So what I did there is I did a combination technique. I timed for 30 seconds, and I split it. What I did was I looked at respirations and pulse together, and the reason I did that is because sometimes if you tell a patient that you're going to monitor their respirations, they may involuntarily change their breathing patterns, and it also could be voluntary as well. So I kind of did it that way, so that way I can minimize any effects of there being any involuntary change in respiration. So the first 15 seconds, I measured his pulse, and for the remaining 15 seconds, I counted respirations, and I'm going to multiply those by 4 to get the results that I'm looking for. So for him, his respirations were 4, multiplied by 4 is 16, and that's normal. The range you want to be in is 12 to 20, so that's fine for him. In terms of pulse, I got a measurement of 18, multiply that by 4, and I got a total of 72. So that falls within normal limits. So that's exactly what we're looking for. So that's a quick example of how to do pulse and respirations together and try to get an accurate measurement. Ideally, you would like to take it for a full 60 seconds because that enhances the accuracy of the measurement. So now we're going to go into blood pressure, and I'm going to get my instruments out. You need a stethoscope and a blood pressure cuff. Now, a couple of things that you need to make sure of is that you're going to locate what is called the brachial artery, because that's where we're going to be measuring his blood pressure from. To do this, we're going to have a similar position with the arm, so we're going to have him resting it on the table. Now, there's a couple of things we do this for. We want to make sure that we keep the arm close to heart level, and we also want to make sure that both of his feet are flat on the ground and that he's sitting up straight. The reason we do these things is because that ensures accuracy during the test. If he's crossing his legs or if he's slumped over, those are situations or positions that impede blood flow and throw off the accuracy of the test. So now, I'm going to move this over here so it's right next to me as I do palpations to get started. So, when you're looking for the brachial artery, you go towards the biceps, and you can have, there's a couple ways you can do it. You can have your patient flex. Go ahead and flex for me. And you feel the tendon of the biceps, and it'll be just medial to that. A much more unscientific way is if you can draw a line from the pinky all the way up, and you'll kind of find it there. And it's what's called the cubital fossa. So I'm going to go ahead and palpate to find it. And once I've located it, go ahead and relax. I'm going to set up my equipment. So I get my landmark ready to go. So now, when you're looking at the blood pressure cuff, there's a couple of things that are worth noting. Here you have a range, and as long as, when you put the cuff on, the brachial artery falls within this range on the cuff, that's what we're looking for. So we want to make sure we can keep it on so we get the most accurate measurement. Also, the cuff should be an appropriate size for the individual that you're testing. If it's a smaller individual, I'll need a smaller cuff. And that the cuff itself needs to cover about 80% of his upper arm. Also, when you apply the blood pressure cuff, you want to leave about a 2-finger width gap from the elbow right here, the elbow joint. The reason you do this is when you put the stethoscope on, you'll need room to put the bell of the stethoscope to hear the pulse. So now, I'm going to go ahead and attach the blood pressure cuff. So the first thing I'm going to do is I'm going to roll up the sleeve so I get the surface that I need. Now, the gauge of the blood pressure cuff, there's a little hook that it hooks onto so you don't have to worry about it falling or about moving around. So I'm just going to keep an eye on my range and where that needs to go. And make sure that it's nice and secure. So I don't want it to be loose.
3.
Okay, so now that the blood pressure cuff is placed properly, I have the artery within the range of the cuff, I have it secured. I'm going to put the earbuds of the stethoscope anteriorly, because that's the way that your ear canals go, and that's going to ensure that you hear the sounds that you're looking for. The sounds that we're looking for are called Korotkoff sounds. Now, in blood pressure, it's represented as a fraction, systolic pressure over diastolic pressure. And what that means when I'm looking at this gauge is that we're going to pump it up, and this is measured in millimeters of mercury. I'm going to pump it up to about 180, and then I'm going to slowly let out air. Now, normal blood pressure is 120 over 80. Anything that's 140 over 90 or greater is considered hypertension, and we want to send it to a physician to get that looked at. However, if I'm testing an athlete for pre-physicals and I get a high blood pressure reading, I may want to ask them, or really anybody for that matter, ask them if they've had caffeine today, ask them if maybe they had to run to the clinic, maybe they've been having an exam later and they're stressed out, because those factors can actually increase blood pressure. So if that's the case, maybe you want to have them come back later and take the measurement again. Especially if you have a file of them with maybe an exam the year before and it wasn't nearly as high. So, like we said, that's what we're looking for. So as I let it out and it starts to drain, there's two things that are going to happen. This needle will, what they do is it'll bounce and it'll start to move. And at the same time that happens, I'll hear the Korotkoff sounds. So the first sound that I hear represents systolic pressure, which is the maximum arterial pressure exerted when the heart contracts. Then the last sound as it disappears that I hear is your diastolic sound, which is the pressure that's put against the arterial walls when the heart is at rest. So like I said, I'm going to make sure that these ear pods, they go, you can adjust them as you need to. Make sure they're anterior for me. I'm going to grab my bell, make sure I locate the brachial artery again. I'm going to place the bell there. Never use your thumbs because, like I said, with a radial pulse, you can hear your own pulse with your thumb. So I'm just going to cup it, a technique of just parading around my 2 fingers here. At which point now, I'm going to just pump it up to the 180 that I talked about. And then I'm going to slowly let it out. And I'm going to listen for those sounds. All right. So I let the rest of the air out. Take this off, and I will take this off the phone. So the measurement that I got was 120 over 75, which, as I said, 120 over 80 is normal, so he is perfectly within normal range, which is what we like to see. So now that I've done blood pressure, we're now going to go to an ear exam. For an ear exam, we're going to use what's called an otoscope. You have this part here where the light comes through here, and then you have your viewing window. First, going to make sure it's on. I'm going to check in to see if I see the light, which it is. So what we're looking for in the ear, when we're doing an ear exam, is first I'm going to go and look around the ear itself, the outer ear, see if there's any lesions, growths, anything like that, discolorations, abnormalities. Now with him, I go around and I look and I palpate for any tenderness as well. And there really seems to be nothing, as everything is normal as well. So the technique that you use when you're getting an ear exam is you're going to take this part of the ear here, which is called the helix. You're going to gently pull up and out. That opens up the ear canal so they easily fit the otoscope. Now, one thing you want to make note of is that a past medical history plays an important role during this step, because if the patient comes in complaining of a pain of an earache, there could be inflammation in the ear canal, and you want to be mindful of that, because if you stick the otoscope in with inflammation, it's going to be very painful for the patient, because there's not going to be nearly as much space for the otoscope. So, have you had any history of earaches, ear problems before?
No.
Okay. So I'm just going to keep in mind that. So like I said, I'm going to pull up and out gently, and then I'm going to stick the otoscope in. Now, another technique is that you're going to put your pinky against the side of their face here, because another thing is, if you insert the otoscope too quickly, you can actually rupture the tympanic membrane or the eardrum itself, so you want to be very gentle. And putting the pinky here provides some resistance to prevent that from happening. So I'm going to open up, and I'm going to look in. And what I'm looking for is the tympanic membrane itself, which, if it's in a normal, healthy situation, is going to have a grayish transparent color. Also, I'm looking for any scar tissue, inflammation, pus, otorrhea, anything like that that shows sign of infection, that would need some type of antibiotics, anti-inflammatories, so you can refer to a physician. And you always want to double check both sides. So I'm just going to do a quick examination of the other side. Once again, starting with the outside, looking for lesions or growths, deformities, point tenderness, anything like that. And have you had any earaches, any problems with this side?
No.
Okay. Same, and it's the same technique, up and out. Just that ear, and then look inside. Once again, both sides have that grayish transparent color that we're looking for, so there's nothing that's abnormal there, which is good. So now I'm going to go into a hearing test. And for the hearing test, what I'm going to perform is what's called the Rhines test. So first thing, you get a tuning fork, and the tuning fork, what we're doing here is we're doing conduction hearing testing. So what I'm going to do is I'm going to strike the tuning fork, and I'm going to have 2 placements of it. First placement is going to be on the mastoid process, which is behind the ear. It's a bony prominence right here. And that's going to be the number 1. So I'm going to tell the patient that I'm going to do 2 different locations, and this is location 1. The second location is I'm going to remove it from here, and I'm going to hold it up to the ear. What we're doing this for is because conduction hearing, the way it works is that sound is conducted better through the air than it is through bone. So if he hears the sound of the tuning fork greater on his mastoid process, that is a hearing deficit conduction hearing loss. So we're hoping to hear it out here. And we're going to do the same thing, compare both sides. So just again, I'm going to instruct the patient that they know this is number 1, and that's number 2. Does that sound good? Okay. So I want to be sure it's clarified for them so they know what we're testing. So once again, we're going to instruct the tuning fork. Now, did you hear 1 or 2? 2. Okay. Same thing, opposite side. One or 2? 2. All right, and that's what we wanted to see. If it's 1, which is the mastoid process location, that just tells us that there could be conduction hearing loss. Now, we're going to do 2 more things. We're going to do a lymph node palpation. The lymph nodes are a part of the immune system. They help carry away wastes, and they could be inflamed just like anything else. However, when lymph nodes become inflamed, they don't return to normal size after inflammation has occurred, like it can in other soft tissues. So there's 2 that we're going to be looking at, which is the anterior cervical and the submandibular. So for anterior cervical, what we're going to be looking for is they line up underneath the sternocleidomastoid muscle. So for here, we're going to go towards the sternum, and they're going to come up this way. So when we're palpating, we're going to use 4 fingers, and we're going to gently touch on both sides. Now, it can be easier for you to find any deformities or swelling or inflammation in the lymph nodes if you have the patient turn to both sides, which is what I'm going to have him do. So first, I'm going to get my palpation, so I know I get the right landmark here. Go from the sternum, we're going to go out, and once I get to the spot, Luis, can you go ahead and turn to the right for me? Okay. Go ahead and turn to your left. All right, good. So for there's no deformities, no inflammation, which is good. So like I said, if they become inflamed, they do not return to their normal size, and that's a condition that you really need to make sure you see your physician about. But for Luis, there's no problems at all. So now we're going to go to submandibular. Now, submandibular, as the name states, it's below the mandible, so which is you're looking at your jaw here. So we're going to be underneath here, and we're just going to palpate. Once again, trying to feel any firm swelling, any deformities, anything that may be lesions or anything like that. And for him, I felt no growths, no lesions, no swelling, which is obviously what we want. The last thing I'm going to do is I'm going to do a quick throat exam. Once again, with the throat, there's a couple things we're looking at. We're looking at the tonsils, and we're looking at the uvula. The uvula is that little punching bag-like structure that hangs from the roof of your mouth, for those of you who don't know. So what we'll do is we'll take our otoscope, and we'll take off the part we use for the ear canal exam, and we'll just turn it on, and it provides a light that we can use to look inside the throat. Now I'm going to grab a tongue depressor as well, because what we're going to instruct our patient to do is to open wide and say ah, as they say. So I'm going to have him open wide, stick his tongue out, say ah, and I'm going to use the tongue depressor to keep his tongue down, and I'm going to use the light to look at the back of his throat. So go ahead and open your mouth and say ah for me. And once again, I'm looking at the tonsils, and I'm looking at the uvula. So what we're looking for, just like everything else, we're looking at swelling, pus. Also for the uvula itself, it could be hanging off to one side, which could be the aftermath of a stroke, or it can indicate an issue with a cranial nerve. None of those were present in Luis, so that says that he has a fine, healthy throat. There's no swelling, inflammation, pus, anything like that, that would indicate possible strep throat or any other conditions like that that we need to refer to a physician for. So those are the walkthrough steps of a quick general medical examination video. I hope it was helpful and informative. I'm Joseph Irizarry. Thanks to Luis Alvarez for being my patient. I hope it was informative, and I appreciate your time.